Yeah, so it's 2 o'clock. It's 2 o'clock here and 1 o'clock in Miami, right? Uh,
It's noon, but
yeah.
close
Oh,
enough.
it's noon. Yeah, it's noon, right? So, hello everyone. Welcome to another PTS meeting. Today we're having Dr. Lei, Dr. Monica Lei. She's a trauma fellow at the Ryder Trauma Center, and she's going to present a case for us about a subclavian artery injury. It's very interesting to have these arterial injuries in the meeting. Every time that we have discussions like this, we leave the meeting with new insights and new ideas. So it's very interesting to have this kind of discussions. So Dr. Lei, feel free to start whenever you want. I'm going to arrange the panelists and the moderation here, and I can maybe if someone has any question, I can just call you and just we can pause a little bit to make discussions, and if not, just go through your presentation, and when it comes the part that you are going to give a pause, we can start the discussion.
All right, sounds good. All right. I'm guessing everyone can see my slides okay?
Yeah, we can see it perfectly.
All right. Again, thank you very much. My name is Monica Lay. I'm one of the second year trauma fellows at Ryder. Here to talk to you about a case we had earlier this month. I'll just hop right to it. I have no disclosures. So this patient was a trauma alert. He was 24-year-old male. It was a walk-in into the trauma center, so no pre-alert. And his chief complaint was that he got shot in the chest. In terms of primary survey, his airway was intact. He was breathing well on room air with clear breath sounds bilaterally. His initial blood pressure and heart rate was 116/92 with a heart rate of 116. And of note, he had a non-palpable radial pulses left upper extremity. GCS 15, and he also was not able to move that left upper extremity, and had decreased sensation as well, particularly below the elbow. And he had two apertures that we saw, one left supraclavicular and one on the left upper back. So I kind of had a quick pause here just in case anyone had questions or wanted to think about stuff just from the primary survey.
Oh, that's great. So let's start with I'm going to ask for Dr. Kirby Gross to give some insights in the primary survey here.
Great. Yeah, thank you. Very glad to participate. And of course, we also have the advantage from the title of your presentation that we can anticipate where the injury may be. So thank you for that. Certainly all our resuscitations start with the primary survey, and some features about this patient, which are particularly relevant: airway intact, hemodynamically at this point, tachycardic, but not significantly compromised. We have the two ballistic wounds, but significantly the loss of pulses and neurologic deficit in left upper extremity. One thing also very important to note is your chest findings. We don't have the chest X-ray yet, but certainly the lack of pulse, the neurologic deficits left upper extremity suggests this may be a distal axillary lesion, certainly where the cord of the brachial plexus are intertwined around the distal subclavian axillary would suggest that may be where the ballistic injury may be. But the fact that there would be no intrathoracic, at least at this point, without the chest X-ray, without suggesting that there's actually intrathoracic injury is very reassuring to us. And certainly then this patient will obviously need to go to the OR. Certainly the patient has hard signs. Hard signs make our job easy as surgeons. That is, it gives us an opportunity to move fairly expeditiously to the OR. However, this patient with the hemodynamic status, and this being a relatively inaccessible area for surgical exposure, one could consider defining the anatomy with moving to a hybrid room, which would be almost ideal for for a patient with potential arterial injury in this location. Thank you. Over.
That's great. I'm just going to move with Dr. Supa. Dr. Supa, please, when discussing the idea of doing maybe a CT scan before going to the OR, would you agree with that idea, or considering that the patient has already lost his pulse in the upper extremity, would you take this patient directly to the OR?
I agree that this injury is difficult to treat surgically, especially when you don't know exactly the location of the injury. It can be any thoracic outlet vessels. And since the patient hemodynamics was quite okay at this point, I think I would send this patient to CT scan, to CTA to check for the anatomy and to plan my surgical approach. But like Dr. Cross mentioned, if you have a good hybrid room with a good angio, you can study the location of the injury by doing that also. But in this patient, I want to get the chest X-ray to see the associated chest trauma, and I would do the quick fast exam to check for his pericardium, for possible cardiac tamponade, and check for intra-abdominal bleeding, because the mechanism is a gunshot wound and we don't know exactly the trajectory of the bullet. Thank you very much.
Well, that's great. So I guess we have a nice warm up here for your case, Dr. Lay. Please move on.
Yes. All right. So we kept going with our secondary survey. On full exposure, still only the two apertures. Again, the left supraclavicular and left upper back. The back wound was actively bleeding. Same motor sensory exam. And here's our little trauma man from our recess note. I made the dots a little bit bigger just so we could see it for the purposes of this screen. But as you can see here, these were the approximate locations of these two apertures, did not cross midline. And here is the chest X-ray that everyone was looking for. So as you can see, there are some ballistic fragments in this left shoulder, neck, upper chest region, but the lung looks up. There's no significant pneumothorax on the left side. And for us, at least, it was a little bit difficult for us to tell whether the clavicle, first, second rib was involved just because of the location of where all these fragments were. And I know someone mentioned the fast before. I don't have the images for that, but the cardiac beat was negative. Belly was fine. And there was lung sliding on both. So while we were doing all of this, at 10 minutes, his blood pressure dropped. So now blood pressure is 60s over 40s, still tachycardic, still breathing comfortably, but this kind of forced our hand. We at this point, we're talking about getting vascular, talking about the hybrid room. The hybrid table wasn't working. I think vascular was across the street in another case. And now he's too unstable to go for CAT scan. So we went to the operating room, gave him 2 units of whole blood. He transient responded, and then he was brought back down the hall to our operating room. We had enough time for a quick recess. His crit was 36 with a -1 base deficit. And I have another pause here.
Great. That's very, very interesting. I'm going to ask Dr. Kasim. He always gives us a lot of interesting insights when it comes to vascular trauma. So Dr. Kasim, what are your thoughts on this case? So you have a probable arterial injury, and the patient is unstable and got some blood units. He's transient responder. So what would you do in the OR? How would you manage this case?
Those of you have seen the movie called Heaven Can Wait. There is a line there where Warren Beatty says, it is all about probability and outcome. So when you see a case like this, where the patient has been shot and he walks into the trauma bay, actually walks into the trauma bay, and you should be aware, you should be at least suspicious. Well, this guy may be compensated, And that's why everything looks so peachy right now. And very soon he's going to crash. So I think that's the first lesson I have learned from treating injuries like this in my surgical experience over the last 40 years. So having said that, I would have started, an IV fluid in the opposite arm, and I would be very, very cautious. Even though a chest X-ray that was done didn't show hemothorax, and I would always be cautious that this patient may crash in the CT scanner, and I should have all the other equipment available if I am deploying the CT scanner as my first mode of investigation tool. Now, let's be real, not everybody has a hybrid OR. I would be surprised if it is more than 10%. 90% of the world does not have hybrid OR. So we need to be talking about conventional therapy rather than hybrid OR. And if you want to talk about a hybrid OR, it's a different ballgame altogether. So let's say the patient, you have a hybrid OR, then you have the luxury of taking the patient to the hybrid OR, where you have two modalities of treatment is available. One, open procedure. The other one would be endovascular procedure. But before you do that, I think you need to resuscitate the patient. And you don't want to be in a situation where you do, resuscitation in a CT scanner or in a room where all the equipment is not available. I think that is asking for more trouble for yourself and your patient. So I think I would take the patient to the operating room, and it is on the left side. Now I have to make a decision. If I don't have interventional radiologists available and interventional radiologists with vascular experience available, and then it will be left up to me what I'm going to do with this patient. If there is a vascular surgeon who is well trained in endovascular procedure, of course, I would definitely ask for his help to see if he would like to help us with putting a guide wire catheter and whatever procedure he wants to do to get this corrected. But more likely than not, in 90% of all the hospitals, such luxuries are not available, and it will become your responsibility to save the patient's life. So now comes the treatment, and I will stop there. We'll come back to what type of incision, how I'm going to approach this later on. Thank you.
That's great. Thank you. So I always say in this meeting that we have the pleasure to have Dr. Varun here, who's a extremely experienced anesthesiologist, and he always gives us nice insights about the anesthesiology standpoint as well. So Dr. Varun, can you comment in this case in terms of how would you manage this and the important things that we cannot miss? Kevin, I don't know if Dr. Varun has his okay. Yes, so Dr. Varun is on the meeting, but I don't know if he can open his mic. Can you?
Yeah,
can you
I don't see his name. I'm looking for his name.
Oh, for me, he's under Dr. Frisbee. Oh yeah, now
Okay,
he's
I was just unmuted. Awesome.
Oh,
okay.
okay.
Great.
Now you need to turn my video on now.
Okay. Why
Thank
do I
you.
not see you though?
Yeah, where it says he, him anesthesia, that's me. See my pronouns?
I see you up on top. I don't see you on the list of participants. Let me just close
Yeah,
it.
I can see myself.
Now you're there. That was very okay. Here you go. I just
Yes,
made you
I'm-
I just made you a
Awesome.
co-host, doctor, so you should be able to turn it on.
Okay.
Yeah,
There you
it's
Okay,
on.
I'm good. I'm
Yeah.
good to go. So from the anesthesia standpoint, I just want to remind everybody. So this is an injury just above the clavicle. That's a zone 1. Now, you know, and from what we know in zone 1 injuries, that has the highest mortality of all the neck or close to the neck injuries. Has the highest of all, you know, tremendous mortality. So I want to second Dr. Kasim comment from that standpoint. Now, if anybody ever saw the movie Troy, when Brad Pitt stabs Bogorius in zone 1 and he kills him on the spot. You know, we know that zone 1 for many years is dangerous. Actually, there's a sketch by Rubens of Achilles being stabbed by Hector in the neck, just above the clavicle, which is zone 1, and killing him, despite the fact that Hector had all this body armor. And actually, Homer in the Iliad, chapter 22, describes zone 1 as the shorter way to death. That was the description. So from our standpoint, you know, when we see a patient like this, you really have to have good access because this thing can bleed to death. Now, ideally, as long as the patient's mental status is okay, it's better done in the OR because we know that on induction, these patients can crash. So the idea is to take them to the OR. So that applies to all penetrating trauma. Unless the patient is, you know, completely unconscious, it's better to induce the anesthesia in the OR because there's a high risk of hypotension, high risk of bleeding. That's the only comment I wanted to make.
Oh, that's awesome. Thank you very much, Dr. Varon. So, Dr. Lay, I think you can move on and we can ask for more opinions in the ongoing meeting.
Let's see. So I'm not going to switch my slide because I have some spoilers on that one, but in going off what Dr. Varon said, this patient was brought to the operating room and then he placed a right femoral central line and left femoral A line prior to induction. I think at this point, I was having a lot of discussion with my attending about which incisions we were planning. I'm not sure if you wanted to kind of talk about this before I moved on or.
Let's see. But yeah. Okay. So I don't know, maybe do you wanna move on, Dr. Lay, or do you wanna?
I can keep going. So
Yeah.
let's see. As I mentioned, we lined them up. We went straight for the medium sternotomy first. So we did this in order to get good proximal control. Isolated all the branches off the aortic arch. At this point, there was good pulses at the subclavian takeoff, and we also opened up the pleura at this point to make sure there wasn't any tension or anything like that, and there was not a rush of blood there. But he still didn't have pulses distal, so we ended up going infraclavicular to try and get access for the subclavian artery, which is what we were mostly concerned about at this point. We picked the infraclavicular partly because you're able to extend it in case it was distal axillary, and because the injury was supraclavicular and we thought the dissection and anatomy would be a little bit easier to see infraclavicularly. So we went there. At that point, we identified the subclavian artery, visually normal here, but non-pulsatile. And then at this point, we also did a left neck exploration. And at this point, vascular was like scrubbing in to kind of help us with all of this stuff. And doing the left neck exploration, we did the sternocleidomastoid incision, identified no injury to the carotid artery. We iatrogenically had a little bit of branch bleeding from the left internal jugular, which we repaired, and then confirmed that there wasn't any trachea or esophageal injury. And then vascular
Can you
called.
summarize that one more time? Exactly what you found there? I'm not quite clear.
So we proximally there were pulses at this left subclavian takeoff. We did
Okay.
the intraclavicular incision, and we identified the artery kind of at like the mid-distal portion, and it appeared normal, but it was non-pulsatile. So at this point, vascular had already been in the room, and at this point, we were debating either removing the clavicle, seeing if we could do some hybrid approach to see if there's anything we could see, or make a different incision. But the main question was if we were taking the clavicle out or not. Because at this point we thought, just based on where the injury could probably be, we were more concerned about it being pretty proximal subclavian artery that we were not really able to see from the infraclavicular incision.
And Dr. Lay, so if I understood correctly, so you have a median sternotomy and an infraclavicular incision,
Yes,
and you don't have any external signs of injury in the subclavian artery. Is that correct?
correct, from the infraclavicular incision that we could see, yes.
But there are no pulses.
No pulses.
Okay, so let me make a quick pause here and just Dr. Kasim commented on this case a little bit, and I just wanted to call Dr. Aurelio Rodriguez as well. He's on the meeting. Dr. Rodriguez, would you consider anything different in this point of the case?
Yeah, I have been trying to get involved for half an hour, but finally I got it. You got my message. Yeah, first comment. I noticed that everybody in the last months I've seen all these vessels injuries mention hybrid. Like a hybrid, it became like a riboa, that everybody talk about riboa, but nobody used it, except Dr. Ordóñez in Colombia. But anyway, so the hybrid thing, for 40 years I did, even when I was in shock trauma, obviously there was no hybrids. But we had to make it clear. Hybrid, as Dr. Im said, could be ideal, right? But it's not 100% necessary. If you have some surgeons can handle this, and radiologists who can handle this, you don't need, and everything closed, you don't need to have a hybrid. But the impression I have is everybody mentioned hybrid, like if you don't have a hybrid, the situation is going to be bad. Number two, it's a little bit confusing. The injury to me seemed like you're talking about subclavian injury for location, right? Then we're talking about the zones of the neck. Okay, well, this guy was, I guess, in between both of that. For me, it is very simple. If the lesion is in the right, the lesion of the subclavia is zone 1, zone 3 of the subclavian. It has two zones, okay? One zone is between the notch of the sternum, and the scalenus anticus, scalenus medius, correct? That's where subclavia came in between those, and brachial plexus as well, who indicate this patient has a nerve injury you haven't mentioned very much, the brachial plexus, correct? And the subclavian vein is on top of the scalenus anticus. That's where you stick when you do subclavian punches. Okay, now, see, if this lesion is zone 2, you don't need to do mid-sternotomy. You do supraclavicular incision, and trying to find the subclavia. Remember now, in the left side, the subclavia come out from the arch, from below. So actually, you want to get a very proximal control of subclavia. You do a left anterolateral thoracotomy. Here is that. They take off of the left subclavia. You put a clamp, and you have proximal control. You don't have to mid-sternotomy. But if you have a proximal injury subclavia in zone 1, then you have to do mid-sternotomy in supraclavicular. Seems like you did that, right? And then find out the subclavia, as far as you say, is okay. You don't see any hole in the subclavian, correct?
So we did the median sternotomy and infraclavicular.
Yeah, you did both. That's what I said. That's what we do in the right side when there's zone 1. Assuming that you did a right incision, okay? But you said that your subclavia observation was no hole, no injury in the subclavia in that area that you saw, correct?
In the area that we could see, but there was an area that we were not able to see that was a little
But
bit.
there was no flow, correct?
No flow.
So that means this has to be more proximal, who has to be in the chest area where takeoff of the arch. That's the only explanation I have, correct? Okay.
Correct.
Yeah, I'm trying to follow because I'm 81, so I get lost sometimes. Okay, so that's my clarification. That's it.
Great. Well, thank you, Dr. Rodriguez. Dr. Kirby, any other comments in this part before Dr. Lay can move on?
Great, thank you. Yes, yeah, sadly, we don't know exactly where the vessels were injured when we approached them, and certainly this, based upon the two ballistic wounds, the location of the injury in the subclavian artery would be could be relatively inaccessible to the supraclavicular or the subclavian or the infraclavicular incision. I'm certain that's exactly why you were then considering to remove the clavicle to get exposure. Yeah, certainly the classic thought about gaining control of the left subclavian is through the chest, and even that's merely to gain proximal control. But certainly you were able to identify the proximal subclavian was okay. Obviously, this vessel is thrombosed, but I think, yeah, I guess I'm actually just interested to hear exactly where you did find the injury. Exactly, was it where it was with respect to the vertebral, for example, and to take off the IMA? So I'm anxious to hear how this unfolds. Thank you.
Yeah, I would like to add something. Dr. Ferrara, I know you're familiar with Ricardo Ferrara with a lot of experience in Colombia. He lent me his one slide. He has a patient with supraclavicular subclavian injury, exsanguinate. He put a Foley, okay, and he do an anterolateral thoracotomy. I keep repeating, and then you can see the proximal take off the subclavian and get proximal control, and then take off. Okay, that's it. In this case was not exsanguinating, right? He just didn't have pulse and correct.
Great. Thank you. Thank you all. Dr. Lei, I think you can move on.
All right. So at this point, Vascular came in and was looking at things with us. They did not want to angio at this point. They're like, you're open already. What they ended up doing was doing a supraclavicular incision in addition to everything else that we had done. And then with this additional exposure, we were able to find exactly where the injury was. There wasn't a hole in the artery, but it was bruised, and that was where we found where it was thrombosed, and it was proximal left subclavian, as I mentioned here, just distal to where the vertebral artery takeoff was.
Can I ask you a question? Mm-hmm. So, considering that you were involved in the case, what do you think was the reason that you found the lesion after this supraclavicular incision? I mean, what was the difference between the infraclavicular that you had, that you were not able to see exactly the point where the bruise was?
I trying to think back, this was 3 weeks ago. We were able to go a little bit more medial on the supraclavicular incision. And I think once we were able to follow the artery from the supraclavicular, then we were able to see exactly from the infraclavicular. So when we were continuing with the operating room, we're kind of switching back and forth between the incisions we used. But I think with the injury itself and then the distortion of the anatomy and us being able to go a little bit more medially, is how we were able to actually find where the injured segment was.
Great, interesting. Okay.
So I had to briefly leave the room because another trauma activation came, but I came back and they had done some more stuff. But Vascular said that they identified a more than 50% intimal tear in the artery, and ended up doing a subclavian to subclavian short interval bypass with native IJ that we had already exposed as part of our neck exploration. Had good back bleeding, proximal and distal, and then after the anastomosis, they did an arteriotomy and embolectomy at the axillary artery, and again, good back bleeding, no clots were seen. And then the post-op pulse exam, which I'm sure everyone was interested about, multiphasic signal, proximal distal subclavian, and good left brachial signal. However, what I thought was interesting was that they
wait a minute, can I interrupt you a minute? So yes. You got already to, so I don't understand. There was a clot there or damage to the artery would need to be repaired end to end. They had to put a graft. What kind of?
There was an intimal tear, and they decided it was not amenable for primary repair. Okay. So it was a subclavian bypass with native vein.
Oh, with the vein,
You-
you use a vein.
Yes.
Okay. Yeah, I missed that part. Okay.
Sorry, I talk fast.
Yeah, you talk fast, but you talk like Argentinian ladies. They talk very fast. You cannot understand what they say. Just looking they're pretty. You don't have to understand what they say. Anyway, so probably there's an Argentinian in your group and writers. Okay. So that was the thing. I still thinking why I have repaired few subclavian injuries, and I don't remember. I remember taking the subclavia, or either I cut in the middle and separated, which is bad, or this inserted from the sternum, which is more complicated. It's not easy to do it, and lift it up. That give me more space. But you were trying to do supraclavicular or infraclavicular incision. I don't know. I never repaired that way, but I guess there's another way to do it.
Yeah, can I ask a question to Dr. Kassim? So, Dr. Kassim, if you were in this case and seeing this lesion, would you consider doing anything different? And why not use a graft, for example? Can you tell us why?
Well, I'm like Professor Rodriguez, I'm confused as well. It looks to me as if you're doing one thing and it didn't work out, then you are going to do the other thing. It doesn't sound like that you had a very good plan to begin with, what exactly you're going to do in a case like this. You hit one button, it didn't work, you hit the other button. That's the way that it's coming across. But be as it may, I think the accepted management of left subclavian artery injury, whether it is due to stretching as you fall, or penetrating through the bullet, or when you fall, you break your clavicle and first rib, and it causes bruise and you get thrombosis. And on the left side, it is entirely different from the right side. I think in my way of thinking, what I usually do in a patient like this, I usually do a thoracotomy first, because I can get access to the beginning of the left subclavian, which is coming from the arch. And once I get that, I can follow that proximally as it branches, as it passes through the splenius anterior muscles in three parts, one below, one before, one behind, one after that, and then becomes the axillary artery. I could follow all that. And also, in a case like this, I don't think I would deploy a vein graft. I think a Gore-Tex graft is quite sufficient, and it works very well in my hand at least. And also, it is not as time consuming as getting the vein out and all the other things that you do.
And it's more available because you said, you have
Right,
to
it is available as well. So what I'm thinking in a case like this, and I think for those of us who are beginning their surgical career, when you see a left subclavian injury, you better have a plan A and plan B, so you don't make infraclavicular as well as supraclavicular incision. In fact, I've never seen anything like that before. Thank you.
Thank you, Dr. Kassim. Dr. Lay, there's a question on the chat from Dr. Edmund Burke. He's asking, so you were able to get proximal control of the left subclavian artery through the median sternotomy by ligating the innominate vein, right?
Correct.
So that's what you did, right?
Yes.
Okay, perfect. So that was his question. Okay, excellent. I think you can move on.
But again, it's confusing. They always talk in the left side to get proximal control. They always used to do sternotomy and supraclavicular. That's what the book said. I didn't prove to be true to completely that. It's very difficult to get the left subclavian from that incision that you mentioned. That's why we always ended doing anterolateral thoracotomy, which actually is part of the book thing that they do sometimes, and getting proximal control, because you don't want you want to have proximal, in vascular surgery, proximal control and distal control, correct? You have to have that, otherwise you get in trouble, And you haven't mentioned the nerve yet, because of the brachial plexus. I would like to know, it was lacerated, was just contused. How do you explain? He couldn't move the arm, right?
Honestly, I don't have a good answer for you there because we were not able to visualize it in the operating room.
It's in
Yes.
between the scalenus anticus and scalenus medius. It's in that corner, and the artery is next to them.
Mhm.
Okay, all right. Those the vascular surgeon, maybe they didn't know how to work the brachial plexus well. All right.
Yeah, and sometimes the hemo and everything is so distorted, it's very difficult.
Yeah, if I remember, we were also having trouble like identifying like which muscle heads were even there, just because of the blast injury. Everything was really kind of distorted.
Yeah, exactly. So there's another question from the chat. Dr. Sandra Milena Gutierrez Cañas. She's asking, what do you think about an approach with supra and infraclavicular with partial sternotomy? I don't know if Dr. Lay, if you discussed this intraoperatively. If not, I think Dr. Kasim, Dr. Rodriguez, or Dr. Kirby Gross can provide some insights as well. Do you have any experience with that?
Carlos, can I answer that question?
Definitely.
Don't do that. You will have one hell of a time identifying, what you want, what you're looking for. That is the worst incision you can do. And there is such a thing called trapdoor incision, where you do a supraclavicular incision, partial median sternotomy, and then anterolateral thoracotomy. Again, some people use that, and other people say, again, this is not a very good incision either, and the post-op morbidity for the patient is enormous.
Yeah, I like to make a comment too. We have the tendency sometimes in Latin America to trying to do many things, and they think sometimes we think doing many things is better for the patient. Maybe in surgery, in trauma, I'm used to do a complete laparotomy. I don't know many laparotomies for trauma because I can get in trouble. Maybe I'm talking like an old man, but I am an old man. But I am telling you that you're going to start all these many things trying to prevent what? For the scar or something like that. It is ridiculous. As I say, Dr. Kasim, you can get in trouble trying to do these many things, trying to avoid a major laceration or incision. So anyway, I'm sorry to interrupt you, Dr.
No worries. Thank you, Dr. Rodriguez. Dr. Lay, one more question coming from the chat, actually kind of a comment, but Dr. Frisbee is telling us, so just resect the middle third of the clavicle and preserve it, and this should afford identification of the structures. So did you actually did the clavicle resection? And no, so you didn't? Did you just, did you mobilize it anyway or?
No.
No, okay, perfect. Okay, awesome. I think you can move on. Thanks.
Okay. I think someone mentioned about vein versus graft. I did ask the vascular surgeon at this point, but they said they would prefer native, and we had already done that neck exploration and the IJ was already exposed. So they said, a lot of the work had already been done. Let's do that first, but that was discussed as well. Let's see, yes, this post-op post-exam, as I mentioned, we had palpable proximal and distal to the repair, good brachial signal, but we were not able to get radial ulnar signal bilaterally, even after the arteriotomy and embolectomy was done. Vascular at this point thought it was secondary to spasm, him being a little bit cold, and that transient hypotension. He was brought to the ICU for pulse watches on a heparin drip, but 500 units non-titrated and aspirin, which is what our vascular colleagues have been doing mostly here. And, everything was closed, like we closed the sternotomy, had a mediastinal drain, a chest tube placed on the left side, which I didn't put on the slide, but he was closed. So I had another little pause here for discussion. I know we kind of talked about stuff before, but I wanted to know what you guys thought about his post-op pulse exam, and also if you think any further imaging was necessary.
Great. Dr. Kirby-Cross, do you think that do you need any images in this post-op?
I tend to, I don't know if I'm inclined oftentimes to get additional information. For example, this patient has the vertebral artery injury, which was identified in the OR. Generally I've been glad to have additional information when it's available. So I would like to know that. One question I do have for you, Dr. Lay, is the phrenic nerve tracks very closely in this region. Was there any suggestion of diaphragm dysfunction post-op? Over?
There was not any concern for the diaphragm. I think we were able to identify phrenic and saw that it was not injured or involved and protected it.
Very good, thank you.
I have a question. Well, what did the audience, the discussant said about this? It was necessary to do. I'm not familiar who put a patient on heparin. You didn't put a graft. Your graft is a vein, right? So to put it on heparin, I don't remember. What I remember, I trained my vascular surgery when I did some time with Dr. Silagi, the guy who invented the 6 centimeters for the aorta in Henry IV. We always did before finish a per string and put a little cannula and do a shot there to see if the anastomosis is correct. This is a general thought, and this is a very small vessel. I don't know, you need to do that. But I never saw that putting heparin to post this. That was the idea of the vascular surgeon, probably. More likely, yeah, of course. Okay, and then the other thing is I have seen few vertebral artery injuries. There's beautiful picture in Netter how they repair the vertebral artery injury. You have a little hole to repair there, because it's teeny tiny hole. I never have seen anybody doing that. I'm sure this can be done. I never been able to do that. They either embolize, and they can ligate it. They ligate it provided, hopefully, the circular Willis he has and the other side open, something like that. But I would like a discussion with maybe some of the other attendees can talk something about that.
Sure. Dr. Kasim, any comments on the heparin?
It's a good idea to heparinize the patient post-operatively for a short period of time, and especially if you have been in the operating room and doing embolectomy, thrombectomy, or whatever you have done. And also, it gives you visualization of how good surgeon you are, that you've done an excellent case and you can go to sleep comfortably without having to worry about it. So anytime you do vascular repair, I always make a habit of getting a completion angiogram or completion, whatever procedure you want to call it, so that I can visualize it and I'm satisfied that I've done a good job and I can go and rest peacefully. As far as the heparin is concerned, it doesn't have to be a prolonged, drawn out affair. You just give anticoagulation for 48 to 72 hours and then you can tail it off. Regarding injury to the vertebral artery, one other way of preparing, Dr. Super few years ago told us that he had an injury to the vertebral artery, which is in the spinal canal area, and he deployed a Fogarty catheter and stopped the bleed, and the patient recovered. He didn't have to do anything more, and after a few days, he removed the catheter, and everything went just fine. So repairing a vertebral artery is not an easy task, and it's
Except in Netter.
yeah, only in pictures, or like they say, only in the movies. Thank you.
Great,
Yeah,
thank you.
one of the things about, and let me ask you, did the vascular surgery do what's supposed to be done, embolectomy, remove the clots, and then irrigate with heparin? So he does that, right?
Yes, irrigated with the heparin.
That's
Yeah,
what
you do that.
normally you do, but I don't know if they do that. Maybe that's with heparinize. I'm not familiar with the heparinization post, but I'm sure it could be a good way to secure that nothing is going to eclode. Particularly when this was direct injury, it was a blast injury from the artery. Yeah.
Great. Dr. Superek, Dr. Kasim cited you about the vascular injuries. How would this management go in your center?
I think for this case, you did a very good job saving this patient's life. It's very difficult injury, especially in bleeding cases, to stop the bleeding in time. My approach to this bleeding vessel, if I thought about subclavian bleeding, I usually use a combined supra and infraclavicular incision, and I try to take off medial half of the clavicle quickly, and I will check whether or not I can obtain a proximal control. If I cannot, I usually extend the incision down to median sternotomy. And rarely I have to extend it to the left side to be the complete trapdoor thoracotomy. But like Dr. Kasim mentioned, this incision is very morbid to the patient. But I actually have few patients survive with this incision from the bleeding left subclavian injury. So I think the incision is still valid in some situation.
Dr. Supra, where are you working? Where do you work?
I work in Bangkok, Thailand.
Oh, Sabadi.
Sabadi.
Yeah, I didn't know where you came from. Nice to meet you, Dr.
Thank you, sir. Actually, the first teleconference that I presented when I was in Miami was the subclavian artery injury from gunshot wound. And at that time, we used a trapdoor incision to save that patient's life. So it was the first teleconference when Dr. Mothos asked me to present that case. So I remember the incision very well.
But I think it has a bad reputation that I never have done one because I heard that it's very bad, complication of that. Yeah.
It's very good that you could obtain the proximal control via the median sternotomy alone, because in the textbook it said that the takeoff of the left subclavian usually is posterior to the arch, and it's difficult to see directly from the median sternotomy alone. But you did the great job to obtain the proximal control and save the patient's life. I think the most important thing about this patient is to obtain quick proximal control, which you did beautifully. Thank you very much.
Actually, when we do the rupture aorta, the repair, one of the steps is proximal control with clamping of the subclavian. It's there in the arch. So it's in the chest. The takeoff of the left subclavian is in the chest. It's different in the right subclavian,
Yeah, that's great. Dr. Lay, there's a quick question in the chat before you move on with the case. So Dr. Gross is asking, what were the intraoperative transfusion requirements?
Oh, yes. So it was 2 units whole blood in recess, I think 2 PRBCs, 4 of FFP, and some cryo and some platelets.
Great, thanks. I think you can move on as well.
Okay. So let's see, he did get imaged. We did get a CTI of his neck and his chest. So I think just in context, I think we finished this case around 4 a.m. or so. And then he was brought to the ICU, resuscitated, and then brought down to CAT scan. As you can kind of see here, there's still all these ballistic fragments, a lot of subacute emphysema, and the chest tube and the drains and a little bit of hematoma and all of that in place. Yeah, so let's play. had like a very small subsegmental right PE, I believe. Rib fractures 1 and 2. On the CTA, they actually mentioned that the vertebral artery was patent, but however, there was non-opacification of that left subclavian artery at the area where the repair was made. And his pulse exam over the next couple hours remained the same on that left side with no distal pulses. So he eventually, while I was sleeping, went back to, we got an angio too after vascular, asked for it. And you can still see some flow, but not as much in the ulnar and radial. So they're worried about stenosis on the actual ultrasound. But because his pulse exam was not reassuring, he ended up going back to the OR with vascular. They did an angio, did embolectomies again, and found thrombus, so thromboembolectomy, and then found that there was a thrombus at the actual anastomotic site. So they redid the anastomosis with PTFE graft, got pulses afterwards, and then patient was brought back to ICU.
You have a lot of
I
echo.
have
when you
some
talk,
images
Doctor.
of the
I can understand because the echo, I guess the echo. But can you repeat what they did? What did they found? Where did they find?
So they originally started with angio, so did a cut down over brachial and then shot retrograde and saw that there was thrombus at the area where the initial anastomosis was. So
Okay.
you can see it just doesn't.
So that's the next question. What did they use to do the repair? 4-0, 6-0? What did they use for repair? You know what kind of suture they use for repair?
Sorry, 1 second. I am getting technical difficulties and my computer's going rogue. I didn't hear the question.
I say what they use for repair. I mean, how they did the repair, continuous, interrupted, what kind of technique they use. The fact that they are vascular surgeon doesn't mean they're perfect.
Yeah, I think if I recall for the initial case, they did continuous proline and parachuted down.
All right.
So they reopened the supraclavicular incision, found the thrombosed bypass, saw a lot of thrombus, and they said that the conduit was viable, but the artery itself didn't look healthy, possibly because of blast injury. So they ligated the subclavian and did a left carotid artery to axillary bypass with PTFE. And then afterwards had good signal, good pulses, and then the rest of his hospital course. I can pause here a bit if people want to talk, but
I think you can move on, Dr. Lay, and then we can have the final comments.
good. So he eventually got extubated on hospital day 3, got downgraded, got discharged 2 weeks after. Was placed on Eliquis partly because of these PEs that he was found to have, and then is actively following up with plastic surgery for EMGs and things for brachial plexus.
Wow, that's great. Very, very interesting case with great discussions. Let me ask Dr. Kirby, any comments in this any of the session, Dr. Kirby?
A great case. Obviously, a patient left with a well-vascularized left upper extremity. Certainly, he'll have some morbidity from his neurologic deficit. It sounded like he didn't have any neurologic deficit from his vertebral injury. But let me just ask Dr. Lay a question. Would you approach with the conversation today? I know you did the median sternotomy at first. Going forward, same case, would you approach through the left anterolateral thoracotomy, or would you do the median sternotomy first? Over.
I think I'd still have to think a lot about it. I think going for the thoracotomy would be a little bit higher on my list of things now because, even though we were able to get the proximal control through the median sternotomy, I think we were lucky and this guy was super skinny with not a lot of fat. He had it was very easy to find, honestly. So I think it would kind of depend on the patient and where exactly I thought things were injured, but yeah, I don't know.
Yeah, very good. Didn't mean to put you on the spot, but certainly that's one of the values of this discussion. I think you heard many of the senior folks talk about the classic teaching as the left anterior thoracotomy, primarily just to gain control. And based upon the plain films and the sites of the fragments and the fractures, you could see it was going to be relatively proximal, not necessarily accessible to the supraclavicular approach, or even taking the clavicle out, but certainly great job. Thank you very much for presenting us today. I learned much from your presentation.
Dr. Kirby, let me just ask you a question about the thoracotomy. How would you perform the proximal control there? Would you just try to compress it? Would you try to dissect and then like clamp the vessel? What would you do in this cases of thoracotomy first?
Yeah, I tell you, it's certainly in my experience, I've only been able to just gain proximal control. I've not really, you don't do the thoracotomy in anticipation of trying to do anything. It's merely to get proximal control. My sole experience in the military, a explosive ordnance officer with a device went off trying to do a controlled detonation, basically a 4-quarter amputation. Controlled the proximal subclavian merely by tamponade against the adjacent bony structures rather than necessarily applying a clamp. And then off to the OR with my hand in his chest as we gain proximal control. So really doing anything is very, very, very difficult because you're working very, very high in the chest. Also, you're positioning your patient trying to do anything above the clavicle. Holy cow, it's just such a very, very difficult, tight space up there, and having the team working above the left shoulder to eventually gain control. So in that circumstance, I was able to control just with compression of the vessel against the adjacent bony structures. Over.
That's great. Thank you. Dr. Supa, any final comments before we end the session?
I would like to thank Dr. May for presenting this educational case, and I learned a lot as usual. And it's great to see you guys. Thank you.
Thanks, Dr. Supa, for participating. Dr. Kasim, any final comments?
Well, it is a good educational case. There are several things that one can take home. To Dr. May, this is what I would tell her. While you're a fellow, you better develop a plan of management, what you're going to be doing when you're let out in the public domain, where you will be the only one who will be treating this type of injury. And if you go into private practice or academic practice or wherever you practice, I think you need to have plan A and plan B so that you have clear idea how you're going to go ahead and put a clamp on the proximal subclavian artery on the left side. There is a special instrument that is available for that, and please research it. And you don't have to go and dissect anything. It's all done with your finger and the clamp, and you put the clamp on, then you get the proximal control, then you can go to work on the area of injury. And regarding the subclavian bypass, what he really did was a interposition graft with a vein, and I think you would have been much better off using Gotex. And also your anastomosis, your interposition suture line has to be perfect, and then follow it up with an angiogram to make sure there are no deficiencies there, and it doesn't allow any clot formation, and then follow it up with heparin anticoagulation and hoping for the best. So this type of case is a very, very educational, and one can take home a lot of pearls. And if you are a resident, you better develop a plan of management, what exactly you're going to do when you get into practice. Thank you.
Thank you, Dr. Kasim. So from the chat, Dr. Ginsburg wants to make a comment. I don't know if he has his mic open already by Kevin.
He's the boss, so you have to let him talk. Come on,
Yeah,
go talk. Yeah,
exactly.
I know.
Exactly.
Yeah,
Oh yeah, he
he's
I
ready.
can talk. I
He's
can
ready.
talk now. First, just want to make a couple of comments. I was hearing approaches and stuff. These cases obviously are not so common. And so, you're hearing recommendations from people's several cases in the past, in many years, you may get 3, 4 of them is what I've been exposed to. Maybe others have had more. But what I've found is that the median stuff for Monica, anterior lateral thoracotomy, as Kirby was saying, you're not going to get a good exposure there, to try to do any type of vascular reconstruction. It's too high up. The left subclavian, as you showed, dives posteriorly. It dives posterior and at a weird angle. So if you really want to get quick control, what I've done in the past is go through the second interspace and then just shove, like Kirby was saying. You can take a sponge on a stick, or you can put your hand and just squeeze it up while you do your median sternotomy, and then get control proximally. Another comment I wanted to make is that although the classic approach is that you can't go through the left supraclavicular, that you can get it in the right side. And I actually made a film for the American College many, many years ago with a cadaver. But anyway, on the left side, Carlos Ordonez in the Pan American Trauma Society meeting I was in several years ago, was in on case presentations, kind of case comments. And he has approached the left subclavian through the supraclavicular. And I wanted to prove it to myself. And I might have missed this. I don't know if you used it, Monica, but while Dr. George Garcia was doing his acid course here, I actually dissected it. And you can get it, but it's deep down. You only get a small portion of it compared to the right side, but you can get to it. So I told Carlos that he was right. You can get it supraclavicular, but it tends to be deeper and dive down further. And then with regards to just a little tidbit on the subclavian artery, it's a very thin artery, and you got to be real careful sewing it. It tends to rip. So just remember that when you're sewing it in. When I used to do a lot of vascular and do ax fems and ax bifems every so often, you just have to be careful in how you sew it in. So that's my only comments.
Well, thank you very much, Dr. Ginsburg. Very, very interesting comments. Dr. Rodriguez.
Yes, I have first that famous incision that you approach the left subclavians or mid sternotomy. I think I don't understand that. I have tried that. I teach anatomy to 10 years when I was in medical school. It's not that easy to do that. Okay, so you do the anterolateral thoracotomy very quickly. The subclavian is there. You don't dissect anything. You just there, like the doctor said before, for control. That's all. How do you control? You can put a bulldog temporarily. You can put a vessel loop with Rumel. Control. Take 2 minutes to do that. That has proximal control, and forget about that. And then you approach the other. I never had done supraclavicular, infraclavicular. In Colombia and South America, we Latinos, we like something, move the thing, the cha-cha-cha, we like to do things different. It doesn't mean it's correct, okay? I don't know. I always take part of the clavicle out, or I lift it up, and I can see everything, I don't know. I taught anatomy when I was in medical school, and it's not that easy to get the subclavia, supraclavicular, or infraclavicular. You don't have a space. You pull the clavicle out, then you put it back when you finish. You have a lot of space. You see everything there. Good case, good presentation. I couldn't hear you because you have an echo in your phone. But it was a good presentation, good case.
That's perfect. Thanks, Dr. Rodriguez. Dr. Lei, you're the star here in the meeting. Any comments, any final comments for your presentation?
I think this is all really helpful. I was hoping for a discussion about incisions, and I think I got it. So
Yeah, awesome. Well, yeah, and these meetings are very, very interesting because we always learn a lot from presenting and from discussing. We have a lot of experts from all over the world, and it's very interesting to have their thoughts on the cases. And I want to thank especially Dr. Rodriguez, Dr. Cassim, Dr. Supa, Dr. Gross, and Dr. Ginsburg for their insights. Also, Dr. Verum for his insights on the anesthesia standpoint. And so I hope to see everyone next week in the next meeting. Thank you very much, Dr. Lei, for presenting the case. It was very, very interesting. And so I see you next week. Bye-bye.
That's the way I look the riders. They never invite me to the riders, but that's another story, I never invite anybody for the ride except your boss who was there in Allegheny, but he claimed he never was in Allegheny. But anyway, excuse me, shock trauma. Is that the way it look like? That's an old picture.
It's someone else's picture, but this looks like Miami Beach. There's a picture of Ryder in my first slide, but very similar.
Okay. It's beautiful. No, I never seen it. I always talk about the Ryder because it was our competition at the beginning of the creation with the intergalactic shock trauma in Baltimore, but I never saw the Ryder. This is nice.
All right. Okay, guys. Thank you. Bye-bye.
you.
See you next week.